I've got Dr. John Campbell on the line with me. So hello, John.
Yeah, hi James. Good to be on again.
I know, I can't believe the time is flying, isn't it? I mean, I've been on the air now 15 weeks, and it seems like only a couple of weeks ago that you were on the show, but that was back in January.
Was it really? Wow. Okay. Right.
Yeah.
Yeah. Yeah. As you
It
say,
was.
time flies.
Now, John,
Yeah.
it certainly does at the moment. Now, John, I don't think you need a full introduction. Everyone knows who you are, but I wonder if you wouldn't mind just reminding us of your qualifications and experience on why you're qualified to talk about all the things we're going to talk about today.
You are. Well, who is qualified to talk about these things, James? The data is so complicated. It's really hard to know what's going on a lot of the time. But my background is I was a psychiatric nurse, and then I was an adult nurse, and then I went into nurse education, and I taught student nurses for 27 years. I was in full-time nurse education, and since I retired, I've done some part-time work on A&E. And I've also been involved in videos and media and education and book writing and article writing and such things. And over the last 2-3 years with COVID, I've really increased on the videos or the media communication side of health education, health promotion, things related to medicine, nursing and health.
Yeah, and just to give everyone an idea of how long you've been doing this for, John, I mean, you started off doing your videos on VHS videos, didn't you?
You know, I actually did. I was trying to work out when this was. I'm pretty sure it was 1990 or 1991 I did the first ones. So yeah, VHS videos, we used to copy those on an old-fashioned machine one at a time and send them to colleagues in various parts of the world. And then we went on to DVDs, which was quite a revolution really when they came out. We could copy 7 at a time and post them off all over the place. Then of course we dematerialized, to use that appalling expression, and went on to YouTube in 2007.
Wow. And of course, now you've got 2.75 million subscribers. A lot of your videos, I was looking the other day, 4, 5, 6, 7, 800. Some of them are around 1 million views you're getting. So clearly there's a demand for your methodical dissection of what's going on, John. Now, to start off with, I do want to ask you a question because this comes up all the time, and it's not just with you, it's Dr. Aseem Malhotra, and it is a small minority of people, but it keeps on coming back. So I thought I'd just ask kind of what you think about this.
Yeah.
So every now and again, I do hear criticism that both you and Aseem you supported the vaccine rollout initially. You've obviously both changed as the evidence has changed, and now you're both shouting from the hilltops about the harms that are being done via the vaccines. What do you say to people who take that view?
I think part of the problem was initially that these were called vaccines, and people like Aseem and myself have got a lifetime's experience of using vaccines, and we know how efficacious that vaccines can be in preventing diseases such as tetanus or smallpox. So the idea that a new vaccine came along wasn't really that revolutionary, and we thought that this could just be accepted into sort of the pantheon of vaccines. But later, in retrospect, it turns out that these vaccines are really quite different in that they are not giving the antigen. They are stimulating the body to produce the antigen itself, and therefore the dose is not controlled. So you might have an mRNA injection and make so many antibodies, and I might make 10 times as much. So that was one thing. Now, why the penny didn't drop as quickly on that was because this is a completely new technology, and we've kind of been drip-fed data. But obviously, between us, James, we've talked about this before. I wish I'd realised the risks were greater somewhat earlier than I had. Although in the early stages, when we're talking about 2020, the data we had was really quite limited. And we were being bombarded, and I think bombarded is the right term, James, to use, by reassurances from officialdom, whether it was the World Health Organization or the Prime Minister or the Chief Medical Officer or the Chief Scientific Officer or the Medicines and Healthcare regulatory agencies. They were all assuring us that these were safe and effective. And basically, looking back, probably somewhat naively now, we took this on trust. I'm a little more of a cynical, suspicious person than I used to be, James.
Yeah, and look, my opinion is I know both of you, both you and Asim, focus very heavily on evidence-based medicine.
Mm.
So there might have been people shouting on Twitter and on social media, but that's not evidence. I'm thankful that clinicians don't base their medical and clinical decisions based upon the sort of what people are saying on social media. So no, John, I'd like to thank you because you are one of the few, along with Asim Malhotra, one of the few healthcare professionals that has put their hand up and said, do you know what? I got it wrong. And not only did I get it wrong, I'm now going to shout from the hilltops about the harms that are being done and try and warn people about what's going on. So thank you very much, John, for that.
Thank you, James. Yeah.
Right. Okay. So first of all, then, we're going to talk about a really happy topic, but it is really, really important topic, euthanasia, because there does seem to be a worrying trend at the moment. And obviously, this question keeps on coming back to Parliament. But first, I'd just like to highlight a story. I did a bit of research this morning, and there's a Paralympic Army veteran told stunned lawmakers in Canada that a government official had offered to give her euthanasia equipment while she was fighting to have a wheelchair lift installed in her home. So basically, a government official, she was trying to fight to get the money to have this stair lift installed. And because there was a holdup, they said, well, why don't you consider, ending your life if it's causing you this much grief? That was in Canada, where assisted dying was made legal in 2016. But we're hearing lots of stories about this, and there's other stories in Canada, but also in the States now, because in different states it was made legal. So in California, for example, it was made legal in 2016, and there are stories now whereby insurance companies are basically saying, well, we won't pay for your chemotherapy because it's too expensive, but we will pay for you to end your life. What are you hearing about all of this, John?
Yeah, I mean, I've only started realizing, the penny's just dropping recently, how the world situation has changed, I think, James, in the past 10 years. I mean, originally, of course, it was a sort of a common saying that, I'd rather go to Switzerland, in the United Kingdom, that Switzerland authorised euthanasia at an early stage. But then we've got other countries following on. Netherlands is another example where euthanasia is really fairly frequent now. And just what has happened to the once great Christian country of Canada really makes you wonder. It's not just the euthanasia, it's so many things in Canada now. It really is quite a disappointment. And other countries going much the same way. There just seems to be this international trend. I went into healthcare because, you believe that human life is important. There's a sanctity to human life. And does sanctity mean that there's a spiritual component there? Well, yeah, I think it does mean that. Human beings are physical, psychosocial, spiritual beings. And you see this spirituality coming out, especially during illness. And especially during terminal illness. So we have this international change, and the pressure is on in the United Kingdom to bring about a similar change as well. And there's quite a few things that are really concerning about this. I mean, one is what I would call the thin end of the wedge argument, and I think you've given two pretty good examples of that there, James, already. Where it starts off with really good comprehensive safeguards, and then, actually, it would be a bit cheaper if you just died now. Actually, do us all a favour and get out of here. This thin end of the wedge argument, and of course we've seen this before. Now, regardless of what your views are on abortion, fetal life and abortion, I think regardless of what your views are on that, I think most people would agree that there's been a liberalisation of the way that the 1967 David Steele Abortion Act has been interpreted. So it started off as very rigid, life of the mother is at risk, severe risk to a non-viable fetus, 2 doctors to adjudicate that is a necessary procedure. Whereas now, abortion is readily available and has been for many years. Are these strict criteria always being fulfilled? there does seem to be a liberalisation, and we're in a situation now since 1967. There's been 10 million abortions have been carried out, so that's concerning. But the other thing that concerns me as a clinician, sorry, James.
Sorry, John, go on. Sorry.
As a former clinician, I've obviously worked with many people that have died. Now, I worked mostly in intensive care and A&E departments, so most of the people that died under my care died fairly acutely. They woke up that morning and weren't expecting to die that day very often. But I have worked in different settings where people die more gradually, more progressively, what you might call a dying process. And in that situation, we have mechanisms, we have drugs, we have morphine, we have midazolam, we have other symptomatic treatments. We can put up syringe drivers. We're able to treat the pain. We're able to treat the distress that these patients suffer from. And as well as that, James, I don't know if you've been following this story, but there's quite impressive new evidence on the potential efficacy of psilocybin in terminal care to reduce anxiety and reduce distress. And I'm pleased to say that in Australia, already, some psychiatrists will be allowed to prescribe psilocybin as from, I think it's next month, from June or July. So many treatments that are available that we can treat people with. So now sometimes when you're giving these treatments, you'll give more morphine and more midazolam to cover the patient's symptoms. And as a result of that, as a side effect, sometimes the patient will die more early than they would do. But you facilitated a good death, a pain-free and distress-free death, we believe. Now, there's a big difference here, James, I feel, is your motivation for doing this. So if I am giving morphine and midazolam, and my reason for doing this is to treat the patient's pain and distress, and I've done this many times, and the patient has died as a result of this, then I feel that I've done my job as a clinical nurse in that situation. I've treated the pain. Unfortunately, the patient suffered from side effects, and that means they've died maybe hours or days earlier than they would do. But the difference, if I give a drug deliberately to end the life of a patient, to me that is the complete difference. So you might be giving morphine and midazolam in the same way, but if I'm giving that with a motivation to end the patient's life, then to me that just changes everything completely. So we have the wherewithal to make patients, allow patients to die pain-free. We can increase the amount of analgesics and dissociative agents that they're giving, and we can facilitate a painful death without the change in the law, which would bring about this thin end of the wedge argument. That is my current view. We have the facilities already. We don't really need a further liberalisation of this law, because we do have to bear in mind the sanctity of human life. And as well as that, dying is part of the living process, James. You know, if I told you were going to die next week, why not get it over with now? Well, I suspect you'd want that time to say goodbye to your relatives. You know, there's the famous story that the generation before us would have known of the thief on the cross. You know, he was being crucified and Jesus was next to him, and he said, "Jesus, remember me when you come into your Father's kingdom." He had that last chance to talk to his God, regardless of what you believe about that. And, you know, to take this away from people is something precious, that we are artificially truncating this remarkably precious, remarkably unique life that we have. Why wouldn't dying be part of life, the same as birth and the same as childhood and adolescence and adulthood and old age? And death is part of this experience. I just feel really strongly about that.
Yeah, definitely. I'd agree with everything you said there, John. And of course, you know, we spoke on the phone yesterday and we both agreed that, you know, the key thing here is informed consent. I'm doing a whole series of shows on end of life care. And that is clear to me. This is where the problems that exist at the moment, which we will talk about in a moment. We've got to take a quick break now for the news headlines.
Yeah, sure.
So don't go away, John. Right. So, John, so we were talking obviously about end of life care. As I said, I'm doing a series on this. I had Professor, well, he is a doctor as well, Professor and Dr. Sam Almedzeh, who's a leading expert on this. He actually wrote he chaired the group which wrote the NICE guidelines, which are now in place. I've got James Bogle on the show next Tuesday, and now Sam and James have written a report for the Lords and Commons, where basically they've assessed a number of case studies showing that things are going wrong in the NHS at the moment. And in a big way as well. I had Denise Charlesworth Smith on the show on Monday, and she represents 800 families where things have gone terribly wrong. And there's a lot of cases and examples where people have come in for quite a minor thing into hospital. They're in fairly good health. Yes, okay, they might have been old. But the hospitals, what they do is they have these checklists. And if you score a certain amount over a certain score, for example, you might be frail, maybe you can only walk a few hundred meters. Well, they check you on these checklists, and if you score over a certain score, they just put you on end of life care, and quite often, believe it or not, without informed consent from the family, and the person themselves, the patient, doesn't even know. This is pretty shocking, isn't it, John?
Yeah, I mean, I must say I haven't experienced that. Every time I've done this sort of assessment, it's always been in consultation with the individual, or usually at that stage in consultation with the relatives. Now, if this is happening in other places, then that really is a very, very significant concern, James. The whole point about healthcare is that it is an agreement. It's a contract really between the clinician and the individual, and you're working together towards mutually agreed achievable aims, and the sovereignty of the individual's choice should be absolutely paramount in that. Now, sometimes there's advanced directives. If the patient is incapable of making decisions at the time, they might have an advanced directive what to do in particular circumstances. Other times it would be the relatives that are acting in the patient's best interest, and usually 99% of the time the relatives do act in the patient's best interest. But if there is decisions being made on me without my informed consent or my relatives' consent, I would be very concerned about that, and I'm sure you would be as well, James. If that is happening, that needs to be exposed, and it needs to be corrected as a matter of urgency.
Absolutely. And I would encourage you, John, if you're talking about this on your show, to have a look at that report.
I will check it out.
It was published it was published last month, and it's called When End of Life Care Goes Wrong.
Yeah.
Now, let's go back to actual euthanasia in Canada. And you were talking about that kind of slippery slope, weren't you, with some abortion?
It's certainly
in Canada originally, it was... Yeah, well, the law originally in Canada was brought in for people that were terminally ill. But it was then, once it was actually in, it was later amended, and I think this was a couple of years ago, so that it could now not just be used for terminally ill people, but also people that are suffering pain.
Yeah.
And so, I think it's quite worrying, isn't it? That and this is what happens, isn't it? That you bring in a law, and then it kind of settles down, that law, and then we see further moves. Now, what do you think the likelihood is of that we will see the law changed in the UK?
The one about pain is a good one. I don't want people to be under the impression that we're in any way deriding the reality of human suffering here, James. I've worked with people that are suffering in a very real way, and most of the time it's possible to significantly reduce someone's pain, if not to remove it. And if we can't do it, we have consultants that specialise in pain relief. So pain can very often be reduced if not removed. But if people are in constant intractable pain, then that is a real issue. But I'm really pleased to say it is the minority of cases where that happens, and it's the same with any type of suffering. Mental suffering as well. Again, usually this is temporary, and the patients can get better. It's just when you're in pain, when you have mental distress, it's very difficult to see the hope. And if you don't see the hope, if you're in a situation where you feel hopeless, then if someone's offering euthanasia, it becomes sort of easier to take it. In terms of the law in this country at the moment, certain aspects of the mainstream media, and we so often come back to this, James, the problem with mainstream media in the UK, really, they pick on particular cases. So, and I'm going to give a personal example here, James. Hopefully I'll be able to get through it. But There was someone with motor neuron disease who said he was in distress and wanted to end his own life. And of course, certain aspects of the mainstream media pick on this as if this one case represents the totality of people with terminal illness. Well, my brother died with motor neuron disease, James. He was 54. And I would have been desperate to have him for another few days, if I could. The idea that he would have died earlier than the disease process necessitated is a distressing one, and an extra few days with him would have been so precious. He did die as a result of the disease process. But the point is that the media picks on particular cases and then extrapolates that to the whole population. This is an intrinsically irrational thing to do. It'll look at one person with pain, they'll send the camera crews round, they'll send the sound system round, they'll send out the oh-so-sympathetic interviewer, and they'll interview these people, and they'll put them up as if these represent the whole of the situation. But as we've said, the vast majority of people in these situations, they can be managed, they can be controlled, there can be social fulfillment, there can be spiritual fulfillment. And to take that away is appalling. So the advocates for this in the United Kingdom at the moment, I think, are largely using this form of inductive thinking. They're saying, well, this is true on this particular example given by the mainstream media. Therefore, it must be true for everyone. But it is not the case. And there is a very vocal, I think it's probably a vocal minority, who very often don't understand the complexity and reality of terminal care. I don't know if a survey has ever been done amongst terminal care consultants and hospital nurses about this, but I would imagine they would think that they have the mechanisms to cope with this already without necessitating additional euthanasia measures. So there's a vocal political movement in the UK, and I really, really hope, James, this doesn't become politicised.
Yeah, me too. And I think, the thing that worries me about this, and I'm against it becoming law in the UK, particularly at a time, I think, when the NHS is struggling so much, because, I think it would be a terrible situation if we see examples like the case I talked about in Canada, where people, because they're not getting the care that they should be from the NHS, are suddenly being offered a different path. I think that would be terrible. I think we need to sort out the NHS. It's in a terrible state at the moment. And I think, so yes, that's my view. Right, John, I know we've got some other topics to talk about here. We're going to take a quick break now, but when we come back, I'd like to talk about these mysterious FOIs.
Oh, that's a good one, James.
After you,
so stick around for that. That's a good one.
Fantastic. Okay, so we'll just take this quick break. So don't go anywhere. Stick with me, James Freeman, on TNT Radio. Right. Now, when John first joined, his camera wasn't working for some reason, but he's turned it on now, and I've got the famous view from his YouTube channel. Hi, John.
Follow the evidence.
Right, John, tell us about these. Yes, that's it. Tell us about these FOIs.
Yeah. So this is an interesting one, James. So what happened was, back in January, I actually did a video on the 6th of January based on a Freedom of Information request from Swindon. And it showed appallingly high levels of myocarditis and pericarditis. Now, I looked at these numbers and I thought, well, they look really high, but it was an official Freedom of Information request. I had the letter in front of me. It was in the public domain. It was signed off by the relevant officials in the Swindon Freedom of Information office that deal with that. And so I did this video on this, and literally within 12 hours of me making that video, they were corrected. So there was a further Freedom of Information answer correcting the previous inaccurate data. And I was delighted to see the new data, James, because it showed that the rate of inflammatory heart disease in Swindon had not gone up at all during the pandemic or during the time of vaccinations. Now, I was a little surprised because we know that during the pandemic, inflammatory heart disease was a complication of acute COVID infection. So I was delighted to see that that was not the case in the Swindon area. I was really pleased for the people of Swindon. And then just a few days ago, I did a video on, this one was from Lanarkshire, a Freedom of Information request. And again, I did a video and it showed that there was quite an alarming increase in early pregnancy losses. There was other things in the Freedom of Information request, but early pregnancy losses, miscarriage and ectopics. And it showed that in the Lanarkshire area in 2022, there was well over 2,065. And then again, round about 12 hours after I made that video, James, there was another correction. And this number was taken down from 2,065 to 982. Now, that is lower than the early pregnancy losses in 2018, 2019, 2020, 2021. So 2021, for example, there were 1,083, and that went down to 982 in 2022. So again, I was delighted to learn that there was less early pregnancy losses in Lanarkshire, sorry, than there had been in the previous 4 years. Now, it raises an interesting question, of course. Now, this is what we call a temporal correlation, James. It probably had nothing to do with my videos whatsoever, unless, of course, someone had noticed that these what's the word I'm looking for? That these errors had been made.
Yeah, I mean, John, as we discussed yesterday, I mean, I've worked in the civil service, and FOIs are taken incredibly seriously. So at the Office for National Statistics, for example, it is a director that signs off every single FOI, and it's a director who is responsible for that area. So they're an expert, and they do read them. They do read them, and and if there's anything questionable, or like, for example, if you were seeing a huge increase, for example, of something, then generally you would get lots of questions from the director to make sure that what you were suggesting is actually correct. So that's number one. It's surprising that we see such big changes to the data, but John, you're much more trusting, I think, than me, or maybe you're slightly more sarcastic than me, I don't know which, to suggest that maybe that was just a chance occurrence.
Yeah, I mean, being realistic about it, James. I mean, the original data from Swindon on the heart inflammation. Looking back, I think people like people of the caliber of Norman Fenton, Professor Fenton, have said that original data was clearly wrong. So I think there was an error there, but there again, it was surprising that the data, the corrected data, showed there was no increase in inflammatory heart disease. So it really is. I mean, I think what we can safely say is whoever's doing these freedom of information requests, as you've said, maybe need to follow the civil service model and make sure they get it right the first time, because we can't keep chopping and changing data. Data should be data, I would have thought.
Yeah, and it does seem surprising that it hasn't increased given the wider context. And obviously we know from lots of data that actually those kind of issues and complications have actually increased over the last couple of years. But listen, I think the question is, it's more of a question, this, isn't it, rather than making conclusions about what's going on there. But John, please do keep an eye on them FOIs now, though, and if any others do get altered after you talking about them on the show, do let me know.
Well, there is another interesting one, James, that's quite interesting from the Office for National Statistics. And this is to do with stillbirths in the United Kingdom. So in 2020 to 2021, there was an increase of 226 stillbirths between 2020 and 2021. And that actually represents an increase of 9.53%. That's specifically stillbirths and miscarriages in the UK. So we do know that they've gone up between 2020 and 2021, and that's quite a big jump, 9.53%. And that one, I did make the video on that at the same time as I did the Lanarkshire one, and that one has not been corrected as far as I'm aware. So that still stands. So that is quite an alarming increase.
And obviously we won't get into this now because, I haven't done enough research around it, but I do know there is a quite controversial, actually, that because there's a time period, isn't it, when a baby's born that it can be called stillbirth. And I know there are quite a lot of families, actually, which are calling out hospitals because the hospital has put it down as a stillbirth or not put it down as a stillbirth, both ways, actually. against
I think
actually
from
what
memory,
happened in
James,
practice.
it's no sign of life and no breathing in a child that's delivered the issues forced from its mother after 28 weeks. I think that would be the definition of a stillbirth.
Yeah, and I know that there's been some controversy in terms of actual how that's then been recorded by the hospitals.
Yes,
Maybe I'll look into
yes,
that and we can
yes,
talk about it another time.
yes.
Right, we're running out of time. We've got 5 minutes left, John, and I do want to talk about this because this is one of those topics where actually, rather than we're looking backwards and saying, well, this has happened, isn't that concerning? This one is more looking forwards and basically raising the alarm, I think. So obviously I'm talking about the World Health Organization and the international health regulations and the debate in Parliament. Tell us what's going on there, John.
Well, basically, there's, as you say, that we reached 100,000 signature petition that people were concerned about these new powers that the World Health Organization is seeking to impose on its member countries in the event of a new pandemic arising. So I produce videos with likes of Mr. Andrew Bridgen on giving talks in this parliamentary debate showing concerns that sovereignty of the individual country would be to some degree ceded to the World Health Organization. And then there's concerns about the World Health Organization. Mr. Bridgen, for example, pointed out it's based in Geneva. I think he said that they enjoy sort of forms of diplomatic immunity. I'm not sure what the taxation situation is, but they seem to be somewhat in a bit of a bubble in Geneva. They'll be getting reports from all around the world, but, are they in the best position to make adjudications about what happens in Carlisle or in northwest London or wherever it is, that they'd have the authority to impose these restrictions? And that because the World Health Organization imposed this would become a legal requirement in the country that is a signatory to this new agreement. And there's quite significant concerns to be raised here because, as we know, we don't really have any democratic control over the World Health Organization. How senior officials are appointed is somewhat opaque, at least to me. There does appear to be some political influences in there. We know that certain particularly rich individuals are major donors to the World Health Organization. And there is a saying that, he who pays the fiddler calls the tune. There's a whole raft of concerns about this. And the idea that this would be passed through Parliament fairly quickly is quite a concern. I think this needs a thorough analysis, and I would have thought that we've got some pretty good doctors in our country who could make decisions about what is going on locally rather than ceding that decision making almost in lifetime to an external body. I think we need to prepare for the next pandemic because there is going to be another pandemic. We're quite sure about that. We could discuss where that's going to arise from. But I would have thought the way to combat that is to have competent local officers making decisions at a local level. This principle of subsidiarity, that we should be making decisions as close to where those decisions are going to be implemented as possible. I don't like this kind of one size fits all from the World Health Organization, and various other MPs don't like it either.
Yeah, and for me, John, look, even if let's just say we'll talk hypothetically here, even if lockdowns were to save lives, I still think that it's up to the people because there's a lot of collateral damage and the side effects to any policies that you announce, and it might be that people, do you know what, even if it saves lives, we rather, like, old people, for example, we've seen interviews with them and they've said, do you know what, I'm at the end of my life. I've only got a few years left. I don't want to be locked in my house and told that I can't go and see all my loved ones. I would rather take the risk. And so I think, this is the thing for me. It's all about democracy and what we want, not having a top-down approach from officials over in Geneva.
I agree, James. I agree, but we are somewhat traumatized by the mismanagement of the previous pandemic. So we'll need to look at the next pandemic in context of what virus or bacteria that happens to be.
Fantastic, John. Well, listen, we have now run out of time,
More to be said.
sadly. But listen, Definitely. Thank you for coming on the show, and I hope you'll come back soon. And keep an eye on them FOIs for me, won't you, John?
Always,
Thank
James.
you so much.
Always good to talk.
Fantastic. Brilliant. Okay, well, don't go anywhere. Stick with TNT Radio for some fantastic more shows.